Hello, my name is Anika Ahmed and I am doing my final video presentation for my Intro to Med Geo class on the Zika virus. What is the Zika virus? The Zika virus is carried by mosquitoes, commonly known as yellow fever mosquitoes, and it is largely transmitted through mosquito bites. However, that is not the true danger of the disease, the virus. With pregnant women in particular, Zika virus is very dangerous as it can travel to the placenta and infect the baby. While pregnant women are the most at risk due to the potential for fetal microcephaly, in which the baby's head is too small, as well as other neurological abnormalities that can impact the baby. Transmission has also been reported from infected men and women to their sexual partners. The history of Zika. It was first discovered in Uganda in the Zika forest in 1947 in monkeys, and then in 1952 the first human cases of Zika were detected in tropical Africa, Southeast Asia, and the Pacific Islands. Zika outbreaks have probably occurred in many locations. However, because the symptoms of Zika are very similar to many other diseases, many cases may not have been recognized. After the first few cases were found in Uganda and the United Republic of Tanzania in 1952, the Zika virus continued to grow. The reach of the Zika virus had continued to grow. In 1969 to 1983, the known geographical distribution of Zika expanded to Equatorial Asia, including India, Indonesia, Malaysia, and Pakistan. In 2007, Zika had its first large outbreak on the Pacific island of Yap. In 2013 to 2014, the virus caused outbreaks in 4 other groups of Pacific islands. During the years after, Zika was spread in Latin America and Central America, and the first case in the USA was identified in July 2016 in Miami-Dade County, Florida. In 2016, the CDC finally took action against the Zika virus, especially with the growing outbreaks occurring in Latin America and Central America. On February 8th, 2016, the CDC elevated its Emergency Operations Center activation to a level 1, the highest level. Physical consequences of Zika. Many people infected with the Zika virus won't have symptoms or will only have mild symptoms. Zika virus is generally mild, and it doesn't really require hospitalization and deaths. Most people infected have these symptoms: fever, rash, headache, joint pain, conjunctivitis, and muscle pain. Why you should be concerned? Zika virus is very concerning in regards to pregnant women. In addition to other people, it can cause neurological damage, specifically targeting the brain or the spinal cord. In pregnant women, Zika infection can cause serious birth defects, such as microcephaly, where a baby's head is much smaller than expected, as well as miscarriages and brain and eye damage to the baby. There are 5 types of birth defects associated with Zika that are not seen with other infections during pregnancy. Besides microcephaly, which can result in a partially collapsed skull, there are decreased brain tissue with brain damage, damage to the back of the eye, limited range of joint motion, and too much muscle tone restricting body movement soon after birth. There is currently no cure for Zika. Zika cases began to decline in the USA in 2017, and currently in 2020 there was no reported cases. However, prior to that, large outbreaks occurred in 2015 to 2016. Cases were reported to the CDC by state and territorial and local health departments using standard case definitions. As you can see on the map, there was a high number of cases in Florida, Georgia, and Texas. This is mostly due to the fact that we're very close to the water. 224 cases were acquired through presumed local mosquito-borne transmission in Florida. Florida had 218, and Texas, which had 6 cases. In the U.S. territories, 145 cases were travelers returning from affected areas. So this can indicate that people who were traveling to Latin or Central America were able to transfer the disease to their territories. However, countries in Latin America and Central America still face Zika outbreaks until 2019 and even in 2018. In 2018, Brazil represented 60% of all reported cases in the region. And other countries such as Panama and Bolivia had high numbers of cases. The GIS-based case study that I will be covering today is based in Colombia and used GIS trends to help create incident rates and maps regarding that. The conceptual design, the objective of the study was to estimate incident rates of the viruses in 2015 to 2018 for Caqueta, which is a region in Colombia, and its municipalities, and develop GIS-based maps for these diseases. Regarding the vertex, people were not discriminated based on gender, age, or genetics. Everyone was used for this study. Only confirmed laboratory cases and suspected cases were used with no other method of discrimination. The natural habitat was taken into consideration as regions in Florencia were prone for vector-borne diseases as there was intense precipitation in 2015 and especially in 2016. And regarding behavior, recent social and political factors impacted internal displacement, as shown in Naiva, which is the capital city, where cases were found in internally displaced populations, with 46.1 cases per 100,000 people in 2015. The methodology design. It was a cohort study as the study determined incident rates between the years 2015 and 2018. It was population-based to determine incident rates, and the results were used to create GIS-based maps. This is a slide of the maps that were created from the data collection that occurred. The exposure group were selected based on if they were confirmed to have the Zika virus or if they showed suspected symptoms based on PAHO and CDC guidelines. The disease status was confirmed through the laboratory tests that were already done, as well as those guidelines. This table shows the results of the study where cases were shown in the years 2015, 2016, 2017, 2018, and where they were divided against the population to give the incident rate of the municipalities. Discussion. Rates for Zika virus range from 0 to 545.61 cases per 100,000 people. San Jose del Fraga, followed by Florencia, where it had 334.10 cases per 100,000 people. El Doncello, which had 339.59 cases per 100,000 people, and Belén de los Andes, which had 224.12 cases per 100,000 people. These municipalities, which were located in the western areas of Caqueta, reported more than 73% of the Zika virus cases of the study. This was very those areas with high incident rates of these infections also exhibited the highest risk for Zika, as expected, because they were the most populated urban and suburban areas of Caqueta. Conclusions and limitations. There was an association found in areas western to Caqueta where those areas were high urban areas. Touristic areas such as the municipality of Belén de los Andes had high incident rates of Zika virus, indicating an area of potential public health concern. Colombia is home to warm temperatures and high rates of precipitation during the years studied in this case study, so it is likely that Colombia would have faced these difficulties with the Zika virus. Limitations of the study. There was a financial limitation with the study, as there was financial limitations that precluded assessment of all patients by laboratory confirmation. And because of this lack of readily available and reliable tests in the case of Zika, they had to use suspected symptoms to use the cases in the study. They did use PAHO and CDC case definitions and surveillance to be as accurate as possible in obtaining the data. The situation is similar to other countries and other published reports about GIS mapping of Zika and other viruses and diseases in the Americas. Although more than 1,079 cases were reported for Zika, only 24.3% of them were laboratory confirmed. There is an overlap in the symptoms of the viruses that were common in Colombia, and co-infections may be more common than previously known.